Thank you very much, Grasa, and to the organizers for inviting me to the session. Disclosure that we have some funding from Ultragenics. So I want to introduce you guys to the field of fetal surgery. So you may not be aware, but for the past several decades, we've been doing open and what we call fetoscopic operations on fetuses with a wide range of congenital anatomic disorders. So what you see here is an open fetal surgery for myelomeningocele. This was working before. The second is fetoscopic surgery. We're doing a lot of catheter-based interventions to drain fluid collections, etc., and of course accessing the umbilical vein to give blood transfusions. So right now this happens really just for fatal or severe structural anomalies. But you can imagine the future, and where we're trying to take the field is to the world of stem cell transplantation and gene therapy, where we could treat a range of disorders. And really the main reasons to do this in utero instead of waiting until the kid is born is that you can induce tolerance to the fetus. You can also cross the blood-brain barrier before it's formed, and of course prevent disease progression, which makes a lot of sense for some neurologic disorders. And some diseases, and you can add your favorite disease here, but some of the diseases that our field has thought about are thalassemias and sickle cell disease, lysosomal storage disorders, spinal muscular atrophy, muscular dystrophy, and the list goes on. A lot of this field depends on kind of the mysterious secret of maternal fetal tolerance. And it's been known for a while that there are fetal cells in the mother circulating, and this of course forms the basis of non-invasive prenatal diagnostic testing for genetic defects. But the other less well-known fact is that there are maternal cells in the fetus. And the fetus learns to tolerate foreign cells and proteins that it sees. And about 10 years ago, the mechanisms by which this happened was figured out by Jeff Mould, a grad student in Mike McCune's lab at UCSF. And Jeff showed that human naive fetal T cells, when exposed to antigens, were more likely to become regulatory T cells that are specifically induce tolerance to that antigen, as opposed to effector T cells, which are shown in red, which is what would happen in you and me. And he went on to figure out the epigenetic reasons by which this happens. And of course, it sort of turns the field on its head, because you recognize that the fetus learning to tolerate the mother during pregnancy is actually just as critical as the mother tolerating the fetus during pregnancy. And this is an important aspect of normal, healthy pregnancy. But you can imagine that we could use that fetal environment to induce tolerance to a whole range of things: stem cell transplantation for blood disorders, and foreign proteins, clotting factors, lysosomal enzymes, etc. So I'll just show you some data from many labs. So this is a paper from our lab where we did an in utero transplant of BALB6 fetal liver hematopoietic stem cells into B6 mice. And on the left here you see T cell proliferation in a mixed lymphocyte reaction, where you see that both the naive and non-chimeric animal have proliferation of T cells, but the chimeric animal down the bottom has no proliferating T cells, and that's graphed in the top graph above. Sorry, I don't know if there's a different pointer I can use, but anyway. But then the third-party proliferation is intact. The Flake lab at CHOP has done this in dogs, where they transplanted maternal cells, taking advantage of the fact that the fetus should be tolerant to mom. And not only did they get some chimeric animals, but then those chimeric animals were able to tolerate a kidney transplant from their mothers without immunosuppression. And another principle is that you can do sort of a two-step approach, right? So we can't condition the fetus. So all you can achieve really with a stem cell transplant is a low level of chimerism that may or may not be clinically relevant for the disease that you're thinking about. But if that tolerance remains after birth, then you can potentially do a booster transplant using minimal conditioning to then cure the disease. And this was shown beautifully in a paper by Bill Parento, who's in the audience and has done a lot of seminal work on this field, showing that mice with thalassemia and sickle cell can be boosted later. You can see their levels going up around 32 weeks with just minimal irradiation. And so I like to say I'm an MD, but MD hopefully doesn't stand for mouse doctor. And so how can we take in utero transplantation to patients? And so one of the things that our community has done is to form a society called iFetus, the International Fetal Transplantation and Immunology Society. We meet once a year. At our first meeting in San Francisco, which I organized with Grasa, we wrote a stem cell transplantation consensus statement, which was, I think, helpful in our efforts to pass through the first stem cell transplantation trial through the FDA. And we're meeting next in Singapore, so please let me know if any of you are interested in attending. And we just wrote a in utero gene therapy consensus statement, and that's the reference down below. So the disease that my group has chosen to focus on for the first clinical trial is Alphathalassemia major. So hemoglobin, as many of you know, consists in adults of alpha and beta chains, but in a fetus, it's alpha and gamma chains. And so a fetus with Alphathalassemia major is missing the alpha chains and ends up with these gamma tetramers that carry oxygen but don't release it. So the fetus gets a condition called hydrops, which is a non-specific fetal distress signal where the fetus develops ascites and pleural effusions. That's shown on the ultrasound down there. There's a 5% carrier rate worldwide. It's a pretty common disease to be a carrier of, but there are very few survivors. Southeast Asia and China, there's more than a 15% carrier rate, so it can be a global health problem. And currently most of the fetuses die or are terminated. However, one emerging fact is that these fetuses can survive if you give them blood transfusions, just like we do for Rh disease at many, many centers in the world. And so we have designed our stem cell transplantation clinical trial to take advantage of this fact, and we're transplanting maternal bone marrow-derived stem cells to take advantage of the fact that the fetus should be tolerant to mom. We're giving a very high dose of cells because we are not conditioning the fetus, and 1% T cells. And we're doing this at the same time as a clinically indicated blood transfusion, so that's the first one is usually given between 18 to 25 weeks. And this was just a long saga, as anybody who's taken their work from the lab to the clinic. But finally, we got FDA approval, we got generous funding from Serum, and we transplanted our first patient in October, and we're enrolling patients for transplantation if any of you runs into an alpha-thal fetus. So here's a little bit of data about our first patient. They presented at 18 weeks with hydrops. The fetus was so sick that we actually had to do an in utero transfusion because we didn't want there to be, fetal demise on our first case. That's kind of one of the risks of focusing on a fatal disease, is that the fetus might die of the natural course of their disease and not because of any toxicity of your therapy. So we did the transplant, we got a reasonable dose of cells, and we did 5 more transfusions. The baby was born near term, there was no preterm labor, and there were none of the severe events that we would have been worried about, like graft versus host disease, and the hydrops did resolve. And so what we learned is that not only does the hydrops resolve, but the clinical protocol is feasible, it appears safe. We're subjecting the mother to a bone marrow harvest, so that's something that we really want to make sure is safe and well tolerated. And that we're just learning more about, it's a fascinating basic science question, studying the hematopoietic stem cells of an alpha-thalassemia fetus that's been hypoxic for so many weeks. And we are seeing some enhanced erythropoiesis. So there's just some pictures of how this all takes place. So mom has a spinal anesthetic and we do the bone marrow harvest. Those cells then get processed in a very standard way using the Clinimax columns for CD34 selection and the toxin testing. And then we do the standard protocol for in utero transfusions using ultrasound-guided access to the umbilical vein. And that's one of our maternal fetal medicine doctors infusing the cells. And after all that work, it's a 2 milliliter slurry that you're pushing in there and crossing your fingers. So to help with this trial, we formed an international prospective registry of patients. And this also speaks to how once you hang up your shingle and say, I'm trying to treat this disease, you hear about more and more patients. So we had never seen any fetus with alpha-thalassemia, and since starting in November, we've gotten 20 prenatal referrals. Some of them have had IUTs, 2 we transplanted, and a lot of our patients, of course, choose to terminate. And we really want to gather some data regarding options for fetal therapy versus terminations, how patients make that choice, what's right for those patient populations, and neurological outcomes, which of course is the question on everybody's mind because there's some high drops which can cause brain ischemia. However, we've had normal neurological outcome in all transfused fetuses that we've examined. So the ethics of it are very important. Of course, we work with card-carrying ethicists to make sure that we're doing non-directive counseling, that we're sensitive to the cultural issues that might arise in largely a Filipino population and Southeast Asian population. We want to make sure that we're not marginally correcting a fatal disease so that instead of having fetal demise and moving on, you have this prolonged hospital course. That's very important that we're not subjecting families to that kind of false hope. And access to care. A lot of these patients are immigrants who need a lot of help with access to care. And of course, as has been said at many times during this meeting, patient representation is critical for planning these therapies. And our long-term plan is to expand to sickle cell disease and beta thalassemia, which of course are very similar diseases that could benefit from stem cell transplantation. And there's loads of preclinical data attesting to the safety and probable efficacy of this approach. So, but if you step back and think about the convergence of what's happening in our society right now, when you take rapid genetic diagnosis, whole exome sequencing, better understanding of maternal fetal immunology, gene therapy, genome editing, it's clear that stem cell transplantation is one of many in our potential armamentarium of treating fetuses with a number of single gene disorders. So we could use enzyme replacement therapy for missing enzymes, for lysosomal storage disorders, gene therapy or gene editing, and even antisense oligos potentially. And that's sort of our list of favorite diseases. You can, of course, add your own. And the principles, as I said before, is tolerance, prevention of disease, and protecting the blood-brain barrier. So we do a lot of the preclinical work in a mouse model. Here's a picture of how we do it. This is from the Flake Lab where a lot of us trained. So we anesthetize the mom, take out the uterus. You could see the pups through the translucent uterus. And in our lab, we inject into the fetal liver, which is both the site of hematopoiesis at this gestational age, this is E13 or 14, but also ends up being a systemic injection. You can also do directed injections into the cerebral ventricles or the muscles, you name it. So I want to focus on just a couple of these benefits. There's some emerging evidence that the fetal therapies can cross the blood-brain barrier. This makes sense. So here are some slides from a project where we've injected the beta-glucuronidase enzyme in mice with MPS 7, also called SLY syndrome. Super rare disease, but it does end up being fatal in utero. Many of the fetuses get high drops. And so here we're showing that once we gave the enzyme, the recombinant human enzyme, to the fetuses, and we look at their brains, here on the flow cytometry plot, we've gated on microglia based on the expression of CD11b and CD45. And on the left is an intracellular stain for GUS-B that shows that the treated animals have upregulation of the GUS. And that's shown graphically here. Interestingly, we didn't see any enzyme activity in animals injected as adults. So this really only happens if you inject in utero. We've seen some improvement in the brain inflammation of these animals. This is a CD68 stain that shows inflamed microglia. And you can see that there's a difference between the treated and untreated MPS 7 animals. These are some, oh no. Let's go back one more. Okay. Maybe if I do nothing, they'll both play. Okay. These are the mice with MPS 7. On the left here, they're homozygous treated, are sort of autistic. They don't move around much in a cage. And if the other video plays, that's going to be the treated cage where they're moving around a lot more, and Carlo, our technician, who's been amazing at running this project, is having trouble catching them. Oh no. You're going to have to take my word for it. They were moving so fast we couldn't take the video. I know, we just tested this, I swear to God. If one of my students, if this happens to them, I'm like, you should have tested this, you can't get up there. We've tried to see if the transplanted hematopoietic stem cells get up into the brain. And so this is an experiment we're doing where we're using hematopoietic stem cells from a donor that's a reporter mouse for CX3CR1, which is a microglial marker. And these are, on the top is a wild type recipient, and you can see the donor cells in the brain, and they we're sequencing them and all of that right now, but they have the appearance of microglia, and they co-stain with EBO1, which is another microglial marker. And again, these mice aren't getting irradiated or conditioned to open up the blood-brain barrier at all. And we've done this experiment in MPS 7 mice, and you can see that when you look at CD68 staining, the MPS 7 mutant sort of lights up like a Christmas tree, whereas the wild-type control does not. And in the blank areas where it's not lighting up is where we have some green donor cells. So we're obviously quantifying that further. But we're encouraged that not only can in utero therapy, can both enzyme replacement and stem cell transplantation could potentially be therapeutic for fetuses with lysosomal storage disorders, especially if you think of transplanting cells that potentially overexpress the enzyme in question. I want to highlight on the idea of transplanting kind of these supercharged stem cells. I want to highlight the work of Grasa, who's done a lot of work creating a mesenchymal stem cell line that expresses human factor VIII, because hemophilia is a disease that we're all very interested in treating, and there are not only immunologic benefits to treating before birth, but that initial period of a year where the patients are not getting factor replacements, but they're starting to crawl around, and parents are so worried that we feel like it does make a lot of sense to offer in utero therapy. So Grasa has transduced these cells with a lentiviral vector expressing factor VIII and transplanted them into her hemophilia A sheep model, which is incredible that exists. And there is an increase in factor levels over the controls without any increase in transaminases. And so the potential fetal molecular therapies we could offer, of course, are protein replacement for lysosomal storage diseases, and X-linked HED is a specific disease where that was just published in the New England Journal. It's an ectodermal dysplasia where you need this protein only during gestation, and they published a successful report of 2 patients, which was super exciting. You can, of course, use the antisense oligos, nusinersen for SMA, and gene therapy, gene editing. And so in terms of thinking about the potential benefits, we talked about those benefits. Cost is another benefit. The 2 fetuses I've transplanted have been, 400 grams, 500 grams, so you can imagine that all the manufacturing problems and vector production problems and the cost of therapy could potentially be alleviated. But obviously there are some risks that we need to keep in mind, both a procedural risk, which seems minimal for an umbilical vein injection because there are so many decades of experience with transfusions in the fetus. Maternal harm is a no-no. We really need to make sure that we're treating the mother as our most important patient. It's an interesting ethical place in which you have 2 patients to whom you have responsibility, the mother and the fetus, and most mothers will take on a lot of risk to protect their fetus, and we need to make sure that we are actively protecting the mom from taking on undue risk. Off-target effects and germline integration are, of course, other things that we need to think about, but there's a lot of preclinical evidence that there probably is not germline integration with the vectors that we're dealing with. And this is really important. We're talking about somatic cell gene therapy. This is not gene editing or gene therapy of cells in a dish, not embryonic stem cell, not what happened in China. We're talking about somatic non-germline gene therapy. So just to really go over some of the data on tolerance, I've told you about induction of tolerance to allogeneic stem cells after transplantation. We're showing tolerance to the lysosomal enzyme. This is again our mouse study, injecting them in utero with recombinant human GUS and then challenging them with postnatal boosts with complete Freund's adjuvant. And you can see that the in utero group does not develop IgG antibodies specific to recombinant GUS. There's a lot of data. This is just one. I just had the slide from one of my own papers. There's a lot of data on hemophilia and inducing tolerance to factor 8 and factor 9 in mice, sheep, non-human primates. So that bit has been worked out over decades of excellent work by my colleagues. And this comes up, you know, do we induce tolerance to the vector capsid so that you can redose? Obviously, that's a huge question on everyone's mind. So the answer is no. You do not induce tolerance to the capsid because, of course, you need continued expression of whatever protein it is to induce tolerance. But you don't sensitize to the capsid either. This is work out of Jerry Chan's lab in Singapore, where they did in utero gene therapy with AAV8 or AAV5 early in gestation, showing that those monkeys did not develop antibodies against the capsid proteins. So the penalty for not curing the fetus with a single in utero injection is not that you can't treat them later on in life. So you could potentially go back because there's no memory response. I went to Matt Porteus's talk yesterday, and I thought this was interesting, the emerging data on existing immunity to Cas9 proteins. And no one has done the study in fetuses, but you would anticipate that besides transferred antibodies from the mom, that the fetus would not, because the fetal environment is a sterile space, they should not have developed antibodies to the strep or staph Cas proteins. And now I'm just going to highlight some papers that have come out through my colleagues' labs and not go through all of these papers in the interest of time, but just to really highlight some really interesting work that's emerging. This came out of Simon Waddington's group in London, where they did in utero gene therapy using AAV9 for mice with neuronopathic Gaucher's disease. That's a disease that can be fatal shortly after birth. And here they're showing on the top the survival curve of the treated mice compared to the untreated mice, which was remarkable. And the CD68 staining, again, for inflammation shows much decreased staining in the treated animals, which is the bottom row. They also injected newborn pups, and here showed that in the newborn intravenous injection, it also treats the brain disease. And so in mice, of course, newborn mice are more like fetal humans in terms of their many of their developmental aspects. This is work from my colleague David Stillman's lab at Yale. They've done in utero gene editing by peptide nucleic acid nanoparticles for beta thalassemia, among other diseases. And they're showing that there's an increase in hemoglobin concentration, decreased hematopoiesis, definitely editing in the bone marrow HSCs, and a survival advantage. So if you're a mouse with beta thalassemia major, fear not, you've been cured. And my colleague Bill Peranto at CHOP has done beautiful work using base editing and more recently CRISPRs for a number of diseases. This is his paper on tyrosinemia. Tyrosinemia is a great mouse model because you can give the mice NTBC, which sort of prevents the accumulation of this toxic byproduct, but then you can take them off the NTBC to see if your therapy worked. And here Bill's team has taken them off NTBC, and you can see in the bottom there the weight gain is similar to between the red and the blue lines, and the survival is similar. So in terms of feasibility considerations, people always ask, well, are you ever going to diagnose these fetuses in utero with a number of these diseases? So many families know that there is a particular recessive disease in their family. Some have had previous affected children. And for some of the diseases we're thinking about, there is universal screening, universal carrier screening for SMA and cystic fibrosis. And of course, the list of diseases continues to grow as we discover more. And ethically, we don't do a lot of screening right now because we can't offer a therapy. But having a viable therapy, of course, might change the equation for recommending screening. So I think the fields of the prenatal diagnosis and prenatal therapy really need to move forward convergently. And regulatory considerations, I learned a lot from writing the IND for the stem cell transplantation trial and really thinking about and starting conversations around what is it going to take for the first in human implementation of, I call it the molecular therapies, so including gene therapy, gene editing, but also the antisense oligos. These are rare diseases, so your ability to do a proper randomized controlled trial might be limited. So in conclusion, we have an ongoing in utero phase 1 stem cell transplantation trial for alphathalassemia, and we are in discussions with the FDA to expand the disease indications to beta thalassemia and sickle cell disease. And in the preclinical pipeline, we're writing an IRB protocol to do in utero enzyme replacement therapy for not only MPS 7, but for some other lysosomal storage disorders for which it makes sense to treat earlier. Genetically modified stem cell transplantation, Grasa's project on hemophilia, but also you can think of modifying the maternal cells that we're transplanting to overexpress various proteins. And in utero gene therapy or gene editing, and really to highlight that we're thinking about somatic cells only. And that we need multidisciplinary conversations to really carve a responsible pathway for in utero gene therapy so that we're all working towards the most ethical, safe way. We're doing this in the context of a Center for Maternal Fetal Precision Medicine I recently founded with my colleague Mary Norton, who's an MFM geneticist, and she's an expert in non-invasive prenatal diagnosis. And we're really trying to make sure that we involve our ethicists and our regulatory affairs committee, and doing a lot of patient outreach and education because so many of these are rare diseases. And I want to acknowledge my amazing team, the thalassemia team. It's a multidisciplinary team that consists of anybody who ever touches the alpha-thalassemia patient and mother, and we really worked hard together to have a clinical protocol that made sense, as well as members in my lab and Solvaleta's lab, who's helping us with the microglia. Our funding for the clinical trial, as I mentioned, comes from Serum and for NIH and Ultragenics for some of our other studies. And most importantly, really the patients. I had to look my first patient in the eye and they said, have you done this before? And, no, I'm sorry, I haven't. But it's really important to have those honest conversations and really think about what are the risks and benefits before you step foot in the water. So thank you.
Thank you for this magnificent talk. I would ask you, how early in gestation do you see the procedure possible for developmental diseases? You don't want to be too early, you don't want to be too late.
Yeah, it's a great question. So the possibility is, you can do fetal intracardiac injections in the early second trimester. That's done routinely for various indications. For our stem cell trial, we're just doing the umbilical vein injection because that was, in conversations with the FDA, that seemed like it's the time to start. We're not actually sure if the umbilical vein or the intracardiac injection is more or less safe, but I think that's something that is also disease specific. Thank you.
A couple of quick comments and a question. The comments are that I entirely agree with you. I would add that when you use vectors in this context, you can get much more diffusion that you can perhaps achieve in adults. I use lentiviral vectors, and while in adults, if you inject in the CNS parenchyma, the diffusion would be very little. In fetus, you can get, for instance, the whole spinal cord covered. So that is another important factor. I'm the chair of the Genetic Alliance UK, and studies done by the Genetic Alliance suggest that even if you don't have a therapy to offer, about 1,000 rare diseases would benefit from knowing pre-birth that the child is affected. So the argument of just considering whether there's a therapy available is a little narrow. For maybe 1/8 of the total of genetic diseases, knowing early would be beneficial in one way or other. My question is, while in the prenatal medical community there are a number of procedures that are well established, if you ask medics in our community, they are quite reluctant to take on fetal gene therapy. What's your take here? Or
Well,
how
I
can
mean-
we change that?
I could talk another hour about that. I mean, I think it's not about the, you know, I'm a surgeon, but I know that operating is not about cutting and sewing. It's not limited to the technical aspects. There's a lot of cerebral aspects to deciding when and how to do a therapy. And for gene therapy, there are so many considerations, but I think that we need to keep working on it because there have been decades of preclinical studies without any human implementation. So, thank you.
So my question is, how did you know how many stem cells to give? Were you not a little bit scared that you would give too many? And then the second part of the question, did those stem cells then contribute as the child was born and continue to contribute? So 2 questions.
Yeah. So the stem cell dose has been worked out in large part by the dog studies that Bill Peranto and Alan Flake have done. The dogs have been given up more than 10 to the 9th per kilogram doses without ill effect, so 100-fold more than you do clinically. And the fetus does seem to be resistant to graft versus host disease. So we have a range in our clinical trial, and we ended up with, you know, we're limited in the amount of bone marrow we can harvest from the pregnant woman, and so we ended up smack in the middle of our dose range. So we definitely have a maximum and a minimum. Actually, we don't want to subject the kid to the procedure if the harvest was no good and we don't have enough cells.
And the continuity in later life, is that reasonable?
Yeah, we're looking at that right now. We're looking at the engraftment and the tolerance to the maternal cells.
Right.
I would ask a short question. So you didn't mention any inborn errors of immunity, like SCID, and I was wondering why is that?
Well, so SCID actually is the very first in human
that's the
transplantation. And I think perhaps we've moved away from it because the postnatal therapies for SCID are reasonable. And so it's definitely a risk-benefit analysis of...
But then if you can go directly to the mother, you don't need, because there is a tolerance and you go directly to the mother, then father.
Yes, yeah. I mean, I think that it's definitely on the table, but I think in our community we're a little more reluctant based on the success, especially with the ex vivo gene therapy results that are coming out now.
Thank you very much.
Thank you.
Thank you, Tippi.